It just stands to me now to welcome everyone, and thank you so very much for being a part of this this event, where we're looking at compassion and caring in isolation. And certainly we're living in unparalleled, unprecedented, extraordinary times, where compassion and caring is more needed now than ever. And we wanted to explore this in the context of the technical aspects, where people have to do the job of supporting, such as with St. Mary's Hospice, which is why we have Tina here.
Thank you.
And of course, you know, Birmingham City Council and their support through funerals, etc. And then of course there's the mental health element, which Jed will be speaking to. Oh, Sharon's just sent me an email. She says she's struggling to connect, David.
Right, okay. Have you got an email address for her, Deirdre, so I can just contact her?
Yeah, I'll just forward you that now.
Okay.
Just bear with me. Bear with me, everyone. Apologies. Oh, it's actually, David, she's copied you into the email.
Okay, okay, right. Leave that with me. You carry on.
Thank you. Apologies, everyone. This is just wonderful about the wonders of technology.
I know.
You may have put your name in, Deirdre.
Beg your pardon, Peter?
She may have put your name rather than Lunar Society.
Indeed, she might have. So yes, well, let's carry on quickly so that we make sure that we keep to time. So, so like I said earlier, Chatham House rules are going to apply here. So what happens in this meeting room stays in this meeting room from the perspective of personal views being expounded, and of course, but still within the tradition of the Lunar Society, we're all about making sure that we're stimulating ideas, having a really good, robust debate, and of course, catalyzing action moving forward. So towards the end of the event, we're going to talk about lessons learned and future actions that we would like to do moving forward. So each of the speakers is going to give their personal reflections in their work life and their personal lives in relation to this topic. They have 7 minutes to do that. And then at about 7:45, we're then going to conclude with comments previous to that, having had a discussion around it. So I see that Sharon's not yet joined us, so I will introduce Tina first. And Tina, if you don't mind starting. So Tina is an incredible person. I've not met her personally, but we spoke yesterday, and Tina told me that she'd been cycling around St. Lucia, which is where my mum lives, just before COVID hit, and she managed to get back to Birmingham just before then, so which was wonderful. Tina is the Chief Executive at Birmingham St. Mary's Hospice. She's a trustee at Hospice UK and Chair and Birmingham and Solihull end-of-life care group. She is an incredibly successful individual in the charity sector, and she has been she was at a branch regional director at British Red Cross. She has a Master of Business Administration from Birmingham City University. She looks way too young to have graduated when it says that she graduated, so I don't believe that that's the date. I won't say what the date was. And she has, you know, some really incredible commercial acumen. She's been involved in overseeing a huge increase in annual income from £2 million to £8 million, raising some really well-needed funds for the hospice's vital work to reach people. And I know she's going to talk a bit more about the community program that she's been able to do and get people together in an incredible planning strategy that turned out to be really well worked for the current crisis that we're in. So I think what I will ask everyone to do is to just mute yourselves for the 7 minutes that Tina is going to speak. And then we will hear from Sharon or Jed afterwards. Thank you, Tina.
All right, thank you very much for that introduction. I'll do my best to live up to it in these next 7 minutes. And yes, I've just seen a colleague of mine back from those days at BCU. Monda, hello, how are you?
Hiya, Tina. I'm glad that me teaching you hadn't had an unduly detrimental impact on your career.
So you're to blame for what I'm going to speak about now. Yeah, so whilst I was in St Lucia, the world changed literally, and we could see the pandemic unfolding in the UK from our bubble way out there in the Eastern Caribbean. And prior to that, some of you will have known that I've been in this role that Deirdre described, the chair of the End of Life group for Birmingham and Solihull. Health and social care, really, across health and social care for Birmingham and Solihull. I've been involved in bringing people together to form a unified plan for palliative and end of life care, because more recognising that as more of us are living longer, hopefully most of us will be living longer well, there'll be many of us who are living longer with multiple conditions. So I could see a tsunami, a crisis in the future. So we started preparing for a future crisis where we needed a much more sustainable way of supporting people at end of life that involved communities and better coordination. So I was really pleased to go to St Lucia, having had that plan agreed across all the organisations across Birmingham and Solihull. And when I came back, it was an absolute, I suppose, awe-inspiring privilege to see that a major part of that had been implemented, and that was a coordination centre has now been set up. We call it HOBS, H-O-B-S, Hospitals of Birmingham and Solihull. And we had already been working with commissioners about how we would set up a coordination centre so that people could get hospice care as quickly as possible. Now, when the pandemic hit, clearly all three organisations rallied together, knowing that at any one time, our clinical staff are right in the front line. Any of them could contract COVID-19 themselves. So we wanted to build that resilience, so we got a stronger pool of staff. And so the HOBS service, which is a 24-hour service, it's one number to contact all three hospices, and it's 24 hours clinical service offered to people in their own homes, an advice line, and also access to the three hospices inpatient units, so that at any one time we could see where the demand is, where the capacity is, and how we can respond more effectively. That was launched on the 6th of April. It took 2 weeks to set it up. So 18 months of planning, 2 weeks to set it up. Launched on the 6th of April, and then it went 24 hours before the bank holiday on the 9th or 10th of April. So I'm so proud that that is now a very, very busy helpline. So that was the first thing. The second thing, really, that I think has really struck me is the flexibility, the compassion, and the courage of all of our staff, frontline staff in particular. It's very scary being in the front line, and yet they're putting the patients well before themselves. And my colleague Jed, you're on the front line too, so my applause is for all of you. And it's one reason why I did a volunteering stint on the inpatient unit as a receptionist, because I wanted to be able to demonstrate that it's like the captain should be there with everybody on the ship, and so I wanted to be there, and I had conversations with relatives that were really distressed because at the time hospices had stopped visiting because we were finding that visitors then started contracting COVID simply by being on a unit where there was COVID-19. 50% of our patients on the inpatient unit had COVID-19. So I was having those live conversations and understanding the difficulty that frontline staff have in having those conversations. So, and then thirdly, I think there's been a lot of government bashing, and the clarity of advice that's come out from government and the clinical commissioning group has been absolutely crystal clear. We were told very clearly about what personal protective equipment we had to have, the types of patients that we have. It meant I had to agitate because the supplies weren't coming through. Deirdre was also put me in touch with the supply chain. But it just shows the power of social media. The clarity of what we needed was absolutely crystal clear for the government and the commissioners. We just simply had to, rather than moan, had to agitate to get it. But it meant that our colleagues in the NHS then rallied together and made sure we could tap onto their supply chain very, very quickly. And because we've been able to do that, there have been a few nursing homes. I think St Joseph's care home, the nuns are praying for me at the moment because I managed to get them hooked into their proper supply chain. So we can all do with a bit of a prayer from a holy sister. But having said that, I think it's just the power of social media and the willingness of the public and the business community to rally to our aid has really made a difference. And that includes a donation of 17 laptops when there was a laptop shortage to keep our, from a local firm, to keep our nurses actually active at a distance from patients out in the field. So they were able to, nurses that have had to self-isolate have still been able to communicate with patients and families through these laptops. So it really has been a whole scale level of support that has kept us going in this crisis. So I think, Deirdre, yes, I've done my best to keep within your 7 minutes, Deirdre, because I know that you're on a time
Tina,
plan.
you did amazingly. You had 2 seconds left.
Okay.
Well done. I think she deserves a round of applause. You know what, Tina? I think from what you said, I mean, it was just so inspiring what you've been speaking about. But it's interesting because inspiration is our new normal. Yeah. And the inspiration was completely across the board. And what stood out for me was that it appears that there were 3 big C's that came out of what you spoke about. You know, you spoke about the coordination, you know, at the very beginning with Hobbs and what's come out of that, what's coming out of that. And then of course there's the courage of the staff. And, you know, and we have to really remember those staff who are behind the scenes as well. You know, those who are the ones who are not normally sung as heroes. And indeed, I'm hoping that when Sharon comes to speak, she can speak to those other types of staff, like the porters, the funeral directors, the grave diggers even, you know, who would not normally come to the fore. And then of course, the other big C is collaborative working. And I for one, I'm just so proud to see how this region has rallied together in a collaborative way. And all those 3 words, coordination, courage, and collaboration, I think are things that we need to walk forward with us out post-COVID-19, that other C word that we won't want to know and hear about once this is all done. But everyone will have opportunity to ask further questions, and please do put your questions in the chat if you'd like. We have had 2 questions already come to us, but we'd be happy to take further questions once all the speakers have addressed you. So Sharon hasn't arrived yet, so I think Jed, I'm going to have to ask you to give your 7 minutes.
That's okay.
So I'll just introduce Jed very quickly. So Jed very kindly agreed to do this, and we only spoke this morning. And it was a fantastic conversation, and I was thrilled to be speaking to a senior art psychotherapist. And Dr Jed Jerwood works for Birmingham and Solihull Mental Health Trust. He's the clinical academic at University of Birmingham mental health, and he's a mental health and palliative care researcher who's worked in mental health services and palliative care for nearly 10 years. He works clinically with adults with severe and enduring mental health illnesses. He provides clinical art psychotherapy on an individual basis in community settings. And last year, he worked at the John Taylor Hospice, working with people with terminal illnesses and their families pre and post bereavement. Now, I mentioned that Jed is a researcher, and his work focuses on improving palliative and end-of-life care for people with mental ill health. And he's really interested in marginalization within healthcare settings. And he and I had an interesting conversation earlier this morning around some of the inequalities that we're hearing about in the press in regard to bereavement and mental health at this time. So Jed, at the current time, due to COVID-19, has actually moved to work in the clinical health psychology team, supporting staff in acute trusts who are coping with working with patients during this pandemic. And within the mental health trust, he's been providing training to their psychology staff who are not used to obviously working so much with physical health issues, and certainly not having to deal with death and dying. So he helps them to feel more confident in their frontline work, but he also helps to support their roles with other staff within the trust. So may I introduce you to Dr. Jed Jerwood.
Thanks, Deirdre. Can everybody hear me okay? I've had so many Zoom meetings. I think this headset's probably on its last legs, but seems like people are doing thumbs up. So yeah, I'm going to speak from I guess a frontline perspective, both as a clinician and as a researcher. And as Deirdre said, my background is as a psychological therapist, and I was a strange breed in that I had two jobs at one time, one in the mental health trust and one in the hospice. So I worked at John Taylor for about 8 years up until last year, and during that time became really interested in how much we separate mental and physical health, and we treat people as kind of head up and neck down, and how actually the people that I encounter in my work don't understand themselves like that. You know, we're all whole people, and our mental and physical health are really connected. And I became particularly interested in the palliative care experiences of people that I was working with in the mental health trust, who seemed to have lots and lots of physical health difficulties, but who didn't seem to I didn't seem to meet them when I was at the hospice. They didn't seem to be getting into hospice care. And so I became kind of interested in the two, really, and it's something that I've been working on for my doctoral work now for about 4 or 5 years. And that PhD is complete now, and the focus has shifted onto kind of implementing some of the findings of that. So I wanted to talk just quickly about the research and how that relates and what's happened in regard to COVID, and then also a bit about the staff support, just building on some of what Tina highlighted as well. So as part of the research, sort of following the research being completed, one of the things I've been doing within the trust is working to develop a palliative care strategy, and worked with some of the partners that Tina's been working with, and trying to help the mental health trust take its place really within the palliative care community in Birmingham and Solihull. And in fact, we were in a meeting finalising our strategy. We're one of the only mental health trusts in the country to have a palliative and end-of-life care strategy. And the day that we were all told we weren't allowed to have any unnecessary meetings was I was in a meeting with my strategy, just about to get it all signed off. And we were all sent home to work from home about 2 weeks before the lockdown. So COVID-19 kind of hit that work very acutely. One of the things that we know from the existing research is that people with mental ill health experience poor physical health and have a life expectancy of up to 20 years less than the general population, and that's one of the biggest health inequalities in the UK. And we know that many of our services at the Trust have really complex physical health problems, and so that puts them at quite high risk really when something like COVID-19 comes along. We have lots of people with different respiratory illnesses, lots of people who have quite complicated physical health, and they're often quite marginalised from accessing healthcare in the way that people without mental health problems aren't. Much of the work that we planned with regard to implementing the strategy, a bit like Tina was saying, you know, we've been working on it for a long time, and it's incredible what we've been able to achieve in a matter of weeks. So having an end-of-life care policy, considering how as a mental health trust we might be providing direct end-of-life care in this environment. Our staff don't provide a lot of physical health care, and so there was a need for upskilling, reorganisation, a lot of planning, so that we could deliver that palliative and end-of-life care compassionately and safely, really. And actually, it was incredible just the mobilisation that happened, but thankfully we didn't see the numbers that we were expecting. So although the numbers nationally have been high, the similar organisation that happened across the acute trusts meant that actually as a mental health trust we were able to transfer our patients, you know, into the acute trusts. Although there are a number of people for whom that's not appropriate and for whom they're much better cared for in our services, they may consider some of our services to be their home. So really, in the last few weeks, my work, I was asked to sort of talk about some personal reflections. My work's changed dramatically, really. My clinical work is taking place over the telephone and by video calls with my normal kind of clinical caseload. But I've been working with a colleague from another hospice to develop the training that Deirdre talked about. So we have a number of psychologists in the Trust who are now providing staff support, but for them, working with death and dying and providing that staff support is a different type of work than that they normally do with patients. So we've been rolling out training in this format, which again has been another challenge. And then, as Deirdre said, I've moved across to work in the clinical health psychology team because the acute trusts have recognised, as you know, as everybody really nationally, that the staff that are working at the front line and in support roles and in non-clinical roles are going to need psychological support both now and going forward into the future. And it's been really heartening for me as a mental health care member of staff to see mental health being raised up and taking priority and being kind of elevated in the national discourse and in the local discourse. So some of the things that we've been doing on the ground, we've been providing cover every day in the acute trusts. Psychologists and other psychological therapists are available every day to go and visit teams where there's been a particular burden or where people are feeling particularly overwrought. We've been running drop-ins in all of those centres as well. That's happening also within the Mental Health Trust. And I just wanted to sort of highlight really some of the issues that those staff have been raising. So they've been raising the kind of things that you'd expect with working with very directly with patients with COVID, working with greater numbers of dying patients, working with a lot of sadness, coping with the lack of family visiting, the impact of wearing PPE, and all of those kind of things that we've heard a lot about in the media. But in addition, they're raising a whole lot of other queries now. I think as we move from sort of anticipation and the first stages of coping with the pandemic into this becoming a new version of normal, the staff in the drop-ins are now raising other kinds of issues, and some of those things are to do with having so guilt, so feeling guilty about being at work and potentially then going home and putting families at risk. Some people are having to self-isolate and aren't at work, so they're feeling guilty about not being there and not being able to do their normal job. A lot of concerns about where people's normal patients are. So I was talking to some A&E staff, and they're really concerned about the lack of people coming into A&E, particularly paediatric A&E, and where those children were and were those young people okay. a lot of distress is being expressed about not being able to do as good a job as normal. So whatever your job is in the NHS at the moment and in the wider care community, many people are not being able to deliver. We've called it business as unusual at the moment. You know, we're not able to do our normal jobs, and that's causing quite a lot of distress to some staff. Lots of people are working outside their usual scope of practice. Lots of people have fears about being redeployed. Some staff are beginning to feel a bit unsupported as we move from kind of crisis mode into, you know, an implementation phase. There's some, I guess we've mobilised so quickly that there are some gaps, and there are some people who perhaps haven't been as informed as they needed to be, and those concerns are beginning to be brought up by staff. And also, we have loads and loads of junior staff and newly qualified and trainee staff in all different disciplines who've either qualified very quickly or they've extended their placements, and they might not have access to mentors or more senior staff in the way that they normally do. So people have experienced this massive mobilisation, incredible innovative changes to working practices, lots of high levels of anticipation. But now some of the fatigue and the frustration is kicking in, and many people are talking about the uncertainty of how long this might go on and how long their work might be affected, and that's beginning to be quite difficult. All of this in a backdrop of social isolation, you know, a lack of usual support mechanisms, the things that we all do at the end of the day to de-stress and unwind. We can't do those things in the same way. Our sports and hobbies, our annual leave, our holidays, the things that make this difficult work kind of manageable is really impacted upon by the social distancing measures and the lockdown. People are struggling without their friends and family and have a lot of fear about the well-being of others. We normally care for people from a place of relative safety. Most of us look after people that don't have we don't have the things that they have, and so we're able to care for them from that place of us being quite safe. And what COVID-19 has made people have to address is that its universal impact means that you may well be caring for somebody who you're putting at risk, or who is putting you at risk of the very same thing that they're experiencing. And that has an impact on staff. That's very different from normal practice. So finally then, just to say something about inequality. I mean, as a researcher and a clinician, and on a personal level, I suppose I'm really interested in equality, and particularly in healthcare. And I think this pandemic has brought into real focus that despite it being a worldwide, universal, indiscriminate virus that can affect anybody, we're not all experiencing it equally, and it is affecting some groups more severely than others. And I know that that's become more prominent in the media. And I think for me going forward, the mental health inequalities particularly are going to affect my work for a considerable time into the future. So thank you. That's all I wanted to say.
Fantastic. Thank you so very much, Jed. Really appreciate your insight, and as I'm sure everybody else on the call has. It's really is quite sobering to hear about how there's isolation within the self-isolating that we've got to do, and that even with the social distancing, it's even more so impactful on people's mental health because of all the issues that they're facing. I mean, and you spoke about, you know, things like guilt that people are feeling, fear, feeling unsupported, whether they are in work or having to care for other people, and it's so hard to manage the struggle. And I'm certain that even employers are finding it really hard to support their staff in managing that struggle as well. And one of the things that I was really hoping that Sharon would have spoken to, which I'm going to try to be Sharon if she doesn't show up in the next 2 seconds. But I can't promise I'll speak for 7 minutes. But one of the things that I was hoping that she would speak to is about the fact that people who are themselves the workers are people too, and very often they're having to deal with losing loved ones themselves and such like. So and yes, and thank you as well for addressing the issues around inequalities. I expect that we probably get a few questions on that as well. So Sharon Thompson, Councillor Sharon Thompson, has not yet arrived. So I will attempt to become Councillor Sharon Thompson for the moment. And I'll just, thankfully we spoke yesterday, and I'll just, I'll try my very best, humble best, to relay what she had wanted to say. So I'll just give you just some quick insight into who Sharon is, for those of you who don't know. Sharon is the Birmingham City Council Cabinet Member for Homes and Neighbourhoods, and she's been a councillor since 2014. She served as Victims Champion for the city from 2014 to 2015, and then she became the local authority's first ambassador for addressing homelessness and rough sleeping. In 2016, she became the Cabinet Advisor for Homelessness from 2017 to 2018, and then she was appointed to Cabinet in May 2018, so she relinquished that position. She has political responsibility for areas such as housing, including homelessness and private rented sector policy, alongside bereavement services, localization, parks, and allotments. She is a really, really strong advocate for collaborative partnerships and has an incredibly authentic and inclusive approach to leadership, much like Tina, I find. So she has been a really passionate advocate for eradicating homelessness within the city. And she's also served on St. Basil's Board of Directors and on the Commonwealth Games 2022 Members Advisory Group. She's currently the local authority representative on West Midlands Combined Authority Housing and Land Delivery Board, the Association of Retained Council Housing, and CIFA Fireside. I don't know where she finds the time to breathe. So she currently chairs the WMCA Homelessness Members Advisory Group and Birmingham Social Housing Partnership. So, right, so thankfully I did take a few notes when I spoke with Sharon yesterday. And we really had a conversation mainly around bereavement. And as I'd said earlier, that the fact that the people who are part of these services, the technicians and the mortuary staff, are people too. And she was saying that she's found that bereavement is really at the sharp end of this whole pandemic. And her view is that everyone, regardless of their race, their social status, everyone deserves a dignified send-off. And one of the concerns that appeared to have occurred was around issues in terms of cultural sensitivities and race sensitivities in relation to dignified send-offs. So this is one of the things that Sharon was at the forefront of ensuring that this would be occurring. The other thing that she wanted to really comment on was around the saving lives. The social distancing saves lives. The people need to understand the government's view that it's better to have fewer mourners at a funeral, as hard and as difficult as this is, in order to keep people safe, to keep people well. But of course, everyone wants to say goodbye to their loved ones, and it's such a difficult time, whereas you want to be there to say goodbye. We have had I recently spoke with a Lunar Society member who lost her father to this pandemic, and she was heartbroken because she couldn't attend her father's funeral. And as you can imagine, the mental stress on her as a result of that, and grieving on top of that, and not being able to say goodbye, was incredibly difficult. But she did say to me that she understood that it was necessary in order to save lives. And I think this is what Sharon was trying to put across. It is tough, but it's the right decision, and it's the only way to slow down the rates of deaths. The other thing that Sharon wanted to talk about was about keeping people's minds safe and well, and the importance, as Jed very succinctly pointed out, of ensuring that staff are well looked after, regardless of where they sit. So Sharon did point out that one thing that she found was that people who were at management level or above seem to be getting more support than people who are at the lower levels within organizations. So there needs to be a push to support people on the front line, and certainly even people behind the front line who are not normally seen as well. So that needs to be something that needs to come out of this. Life as we know it is not going to be the same for quite a while. And certainly we need to look at different ways to support. We need to look at different tools to support people around grieving. When my conversation with Sharon yesterday, she said she doesn't have all the answers in relation to that. And she's hoping that some of that collaborative working that Tina spoke about would bring together technicians and professionals who can support with those, looking at those different types and innovative ways of supporting people with those tools for grieving when they're isolated in their own homes. This is something that absolutely needs to be done. And of course, we need to consider that those people who are working themselves in the cemeteries, the funeral directors, the mortuary staff, they are under incredible pressure. And she said that she really feels that they are being left behind, frankly, in this whole pandemic. So that was my attempt to be Councillor Sharon Thompson for 5 minutes. So thank you very much, Jed. I saw that thumbs up. Thank you, Clive, for the clap. Please let Sharon know that I tried to do her proud. So now we're going to just go on to just have a bit of a discussion around what we've heard today. Right, so what I have had some questions from some individuals, from Stuart Guy, David Clark, and Peter Bortello. I don't know if Nikwat Marwat is still on the line. I've not seen him. David, is he still here? I suppose not. Okay.
He's here. His box has gone from my...
His box has gone. Well, Nikwat is a gentleman from The Delicate Mind, and which is a mental health charity based here in Birmingham, and he was going to speak to the inequalities and cultural sensitivities in relation to this pandemic. But if he's gone off, hopefully he'll come back on whilst we're on. So I will, what I will do is I will call on particular individuals to ask their questions, those who've sent them in. And then after that, I'm sure we'll have time. Then if people could just raise their hands, and then you can ask your question. I will take, the discussion will go on until about 7:45. Well, 7:40, 7:45, and then we'll conclude with just some views on some lessons learned and future actions moving forward. And what I'm hoping to do is that the Lunar Society will support with catalyzing any action moving forward. And then we'll have an applause for the carers and also for those staff who are not normally seen on the front line. And then, of course, I really do want to remember those who have passed as well. So the first question that I'll take is from Stuart Guy, please.
Hi, Deirdre. I'm an environmental consultant, and I do worry about the effect this is having on everything to do with the economics, the way in which we live, and the mental health, because it's having a tremendous impact. And I do feel that it would have been worth trying in some places to do partial isolation and to allow those who can to get on with life and jobs in order to keep at least some of the operation going.
Right. Was there a particular panelist that you wanted to direct that question to?
No, not really. I mean, I think everybody's already said those problems of people who are isolated and the loss of economic income to those at the usually at the bottom end of the social hierarchy. It will impact upon their lives so much that it could actually result in far more deaths or early deaths or less healthy lifestyle in the next 20, 30 years.
Indeed. Do any of the panelists want to take that question, or shall I put it out to the rest of the group to probably have a view? Tina?
I can do a partial view, perhaps less on the economics. So another member might be able to respond more to that one. But it resonated, Stuart, your question resonated with a conversation that we'd had on our COVID forum. We meet as a group at Hospice on a forum every morning at 10 o'clock. And one thing that we were talking about is this terminology called moral injury, which creates an aftershock that could be as difficult to come to terms with as a post-traumatic stress disorder, in that amongst some of the things that you're saying is that human beings now are having to face so much change that they don't know how they feel. And with some of our clinical staff, they're having to make constant, difficult decisions that will feel against the way that they would normally work. For instance, stopping a whole family coming in and visiting. We've normally got very open, no rules about that. And so for compassionate staff to have to say, even that we can only have one person at the bedside and having to be completely gowned up, and also having to communicate in very different ways, with your face covered and I suppose dressed in a boiler suit and looking completely alien to the way that you would normally present yourself. Lots of very moral issues that they're wrestling with that are creating a lot of that guilt and feelings that they haven't had before, that they haven't been able to come to terms with. So we're working with our local NHS trust to look at how we can support people best with that moral injury. There's a lot of support lines out there, and we've got our own employee assistance programme. But again, I think what you're saying, Stuart, is the economic impact on someone. It's very frightening when many people are, less than a month away. I know that there's a lot of mortgage holidays and rent holidays being offered now, but once those holidays are finished, people have got a lot of financial debt to catch up on. So it will be very, very frightening for many people.
Jed, you wanted to?
Yeah, I just wanted to sort of, kind of echo really and build on what Tina said around the kind of moral injury work. And I think that the approach that the acute trusts and the mental health trusts have taken, and I would hope it's happening in other trusts outside our area as well. I know discussions must be going on within the hospices about how to support staff, but the importance really of that early intervention, the model that is being adopted is called psychological first aid, and it comes from that kind of knowledge that we've got from other disasters and situations that have happened previously, but that the importance really of getting in and providing some early support and scaffolding and helping people to continue their work is really important. And some of what we're finding in the drop-in, so there's a kind of tiered model. You can phone a national helpline entirely anonymously, you can come to a drop-in, you can access something within your trust. There's peer supporters that have been trained as well, so people can talk to somebody who's also a clinician within their trust or another member of staff, and then there are psychologists and psychotherapists available. So it kind of, you know, as it escalates, there's also a pathway for staff that might find them in a very acute state of distress. There is a pathway also into, you know, proper psychiatric support where somebody perhaps is having suicidal feelings or those very extreme reactions. But the moral injury, I think, is quite far-reaching. So for some people it is very much, I couldn't provide that care that I wanted to provide at the bedside at the end of somebody's life. But for other, we're getting lots of different clinicians come in who you wouldn't necessarily expect, and quite a lot of frontline and I like Deirdre's phrase, behind the frontline staff as well, who just feel like they can't do their normal job. And that sense of your own, Neil Greenberg has a really lovely definition of moral injury, which I'll try and find and share on the screen, but about the fact that it's your own, it's where something comes up against your own morality. And so because we're all individual, something that I might feel comfortable doing and that I can reconcile with myself in a colleague might cause great distress. And you know, we see that a lot in palliative care, where perhaps we're used to being around death and dying a lot. But for somebody in a mental health service, being around death and dying is associated with something we should be preventing. It's very much associated with dialogues around suicide and suicide prevention. And so normal dying is something quite alien. And then COVID-19 has created this abnormal dying as well, this unusual way, you know, the ways that people are dying. And so the potential for moral injury is big, but it's been really impressive the degree to which that's been taken seriously and that services have mobilised for frontline staff, not just clinical, you know, for all staff. I've had today, I was just jotting down, I've had a porter come into a drop-in, some receptionists, some administrators, some members of the housekeeping team, because they're all the people that patients talk to. Often they won't talk to people like me because I've got psychologist in the title or psychotherapist in my job, but actually the person that they do feel able to is that person that's around. And so it's really important that those staff can access the support that we provide as well, and that they know they can access it, that they don't think it's just for clinical staff, I think.
Thank you, Jed. Stuart, was that right?
Yes, I think that reflects what I was trying to get at. Right, could I just add one point as well?
Of course.
I support a school in Bangladesh, and the person who built this school is one of our Rotarians, and he is expecting, because of the shutdown in Europe and the way in which we no longer want to buy goods from them, that there will be hundreds of thousands of people dying of starvation in the next 6 months. And there's nothing anybody can do about it. There is no system in Bangladesh to stop that. Now, we can say it's not our fault, but at the same time, we have a moral responsibility for perhaps the people who have supplied us with these cheap goods for many, many years and put up with conditions that we would never dream of doing so. That's just a point. It's not. It's a side effect that we don't take into account.
Indeed. Okay, well, thank you very much, Stuart, for that question. That was really insightful question. We have a question from Peter Bortello, the Vice Chair of the Lunar Society. Peter, I think you need to unmute yourself.
I'm unmuted now, sorry.
Thank you.
I've got two questions. One is for Tina, the other one for Jed. I'll try to be as quick as possible. But the question for Tina really is, I mean, you'll realise what my background is once I've asked the question. But on the background of current coronavirus climate, the effect of admitting seriously ill clients to, say, most hospice from hospitals or the community result in any difficulty?
You get that question.
And the second question is to Jedri. COVID, do you think that mental health will still remain the Cinderella of the NHS? As you may guess, I'm a retired doctor. I'm a GP. I'm working within the CCG, so you can see what my background is there. So, Tina, I wonder if you can take me up on that and see what.
Tina, you need to unmute yourself, love. You're muted.
No, I'm.
Could you just repeat that question, Peter, because it got a bit distorted halfway through speaking.
Okay. On the background of the current coronavirus climate, did the effect of admitting seriously ill clients to St. Mary's Hospice from hospitals or the community result in any difficulty? The main driver is it was there an issue with admitting patients to St. Mary's because of the hold up in getting patients tested and such like.
Having somebody tested wouldn't impact upon whether someone would be admitted. So we did find there was a period of time when there were fewer admissions. Strangely, it seemed like we weren't as full to capacity as we normally were. Now that was probably for a number of reasons, and I think one was particularly during the time when visiting was restricted, and we also thought that some people were preferring to be supported at home rather than being admitted into any type of institutional establishment for fear of picking up COVID. Certainly we were finding that I would say some of our patients were being admitted who did have COVID, and that wouldn't be a reason why we wouldn't admit. One of the things that was threatening admissions, or threatening us, because we have a caseload of 500 patients at any one time at Birmingham St Mary's Hospice, and most of those would be in individuals' own homes, and we've staffed the inpatient unit for around, at the moment, demands around about 15 beds. And one of the things that was threatening that was access to personal protective equipment, because a ruling came in about the type of masks that needed to be worn that were the fluid resistant type masks, and there was a dire shortage of those. So that was a very big threat, because it meant we wouldn't have been able to visit patients in their own homes, and we wouldn't have been able to admit patients because we hadn't got the right stock in. We overcame that. A lot of time is spent scrabbling about beg stealing and borrowing, but we've now got a regular, I suppose, a pipeline of supply now, thanks to a whole scale effort, including Deirdre, who put suppliers in our direction, that I was able to, we can't source those at 500,000 masks from China, but we were able to put those in touch with the procurement. I think the other thing in terms of difficulty around admission has been more, I've just been absolutely overawed by the fact that with HOBS, it has meant that staff who've normally been employed working between the hours of, say, 9 till 5 or 8 a.m. to 8 p.m, within a fortnight changed their working practices to be working overnight. That's a very big thing. That's a massive ask on your staff. They're under normal circumstances, that would take a long time and a lot of consultation to get to that point. But it took the process of a week for staff to sign up and agree to that. We thought that would be a difficulty, but it absolutely wasn't. And the night time is a frightening time, so we need that service overnight. So what we thought might be the biggest difficulty was changing working practice and working patterns. Also, cleaners. Funny thing, cleaners are very difficult to get hold of at the moment. And so rather than furloughing all our staff who like fundraising staff, fundraising events have obviously dried up, we can't hold them anymore. But those that were prepared to learn how to pick up a mop And mopping and deep cleaning is a very skilled job. We have fundraisers who are doing deep cleaning now and housekeeping, working on reception or covering a bereavement helpline. So that was another thing, is changing all, you know, we were going to launch bereavement hubs into the community. What we've now is turned that into a bereavement telephone service where people have got, and that now that was launched at the beginning of the week, and we anticipate that's going to be a very busy service too. So we're now working across the CCG to look at how we connect up with other bereavement services. So a different type of difficulty. Does that answer your question, Peter?
It's a very nice picture of how COVID has in fact altered the scene, I suppose, from a straight, you know, referral type situation and such like, to now there's a bit more, again, cooperative working, and obviously people are a bit more illuminated about what work they could be doing. So that's very good to hear. Thank you very much. Thank you.
Peter, you had a question for Jed.
Yes, I'm really sorry. I don't mean to hog the screen or anything, but basically it says post-COVID, does Jed feel that the mental health services will still remain the Cinderella of the NHS?
Well, I'm an eternal optimist, so I hope that one of the positive legacies from this, and I say that without wanting to minimise the massive negative impact that it's had on individuals and families, but I think there are some things that we've been able to do, that we've been trying to do for a really long time, that we've kind of shown ourselves really that how quickly we can mobilise, and one of those things is the prominence of conversations about mental health and psychological support and well-being. You know, we're talking a lot about well-being, and I think there's you know, we often feel a bit marginalised, you know, in mental health services, as do palliative care services. Actually, you know, there's great similarities between the two parts. We're sort of pushed out a little bit, and I think that our ability now to work together and to connect across mental health, physical health, and palliative care means that I think we all value each other much more, and I see that in, you know, on clinician to clinician relationships, you know, on the ground, people working together, but also, you know, I've been really struck by the leadership within my own trust, as well as in the partner trusts, and the people's willingness to
I'll come with you in a minute.
pull together, like Tina said, to do hobs. You know, I've been around while those debates have been going on for a long time. For us to be able to have a palliative care strategy that talks about our partnerships with the hospices, there's some great things that have been done, and I hope that filters up to the government, and that some of the positive narrative stays. You know, but yes, I'm optimistic, but you know, I'll try and keep with that. Yeah, I hope so. I hope you all feel optimistic too.
Thank you. Can I just say something, Deirdre? There, I'm a bit I'm a bit of an optimistic pessimist, if one could say that, if there's one. But I think, I mean, mental health, from my background as a retired GP now, and such like, has always been a bit of a difficult nut to crack. You know, accessing it from primary care and such like, not all that difficult, but obviously it becomes an issue if there is a bit of a breakdown in communication. Having the help of people like Prince William and quite a few people who have got some interest in you know, furthering the idea of mental health, shall I say, surely we should be able to retain the impetus that COVID has made us realize we need, both within the NHS and outside the NHS in a way, that we should be able to convince the successive or whatever governments or the powers that be, that mental health should not remain in the background or marginalized, as you've put it. So I hope, and I wish you the best, obviously, I hope that things do keep on at this same level, if not better still.
Yeah, thank you.
Thank you. Thank you, Peter.
Thank you.
So now we have a question from David Clark.
Yeah. I think actually the question I was going to ask, I'm perhaps going to put on one side, if I might, Deirdre. I suppose actually, because it's Thursday evening, and 8 o'clock is what, about half an hour away. And I'm very conscious, particularly because my daughter is a physio within the NHS and my son-in-law is a GP within the NHS, of the impact on them. And we all go out at 8 o'clock on Thursdays, or many of us do, and we applaud those who are within the NHS and in care settings as well. Very simply, I mean, how important is that kind of show from the public to those who are working in the NHS? And is it, in a sense, perhaps more important for the public to be doing this than it is for those who are the subject of our thanks? And the second point as well is, how do we actually exit, if we ever do exit, from this level of thanks that we're giving those within the NHS? Because that strikes me as being almost as problematic as some of the problems that Boris and the government face in terms of our exiting from this current scenario. I suspect this might be one for Jed, actually. I'd be interested in his take on this.
Yeah, thank you for the question. I think it's really interesting what's happened with the clapping on a Thursday. My partner's a nurse, and obviously I'm a mental health worker, and many of our friends work in the NHS. And I think for a lot of people, initially, there was this sense of, well, it's lovely. It's really lovely that people want to clap, but what we need is, government support. We need PPE. I think right across health and social care, people have been struggling with the lack of investment and some of the cutbacks that we've had to accommodate over the years. So in some ways it felt, I think there was a little bit of cynicism until it happened. And then what happened when it happened on the first night, it was incredibly moving, actually, I think, for me, and certainly for some of my more cynical friends and colleagues and family members. Actually, it's very hard not to be moved by a show of solidarity. And then as the weeks have progressed, and that clap has become about a broader range of care staff, not just the NHS, not just frontline staff, not just the nurses and doctors that we see in the news, but people are aware that there are allied health professions, like you've mentioned. There are non-frontline staff, and behind the frontline staff, there are senior managers, and there are all sorts of other people. There are care workers and the care homes. We've heard a lot about them this week. And then it became about other key workers. And I think, and then it became about, actually, it was a chance to see your neighbours and to connect. And Tina will speak about the compassionate communities work that's been going on within palliative care for a long time, which is about that kind of neighbourhood connection that many of us feel like we've lost. And I know in my street now, the clap at 8 o'clock, it is about the NHS and it is about what it's about, but it's also a chance to wave down the street and to say hello and to connect and to come together. And I think that's made me feel personally, and I can only speak, as an individual, I kind of enjoy that it's become a broader thing. I mean, my hope is for a greater understanding of what the impact of austerity has been on the NHS. Without getting overly political, I feel as though I hope that people are feeling less cynical about it and see its value in a different way post-COVID. And I wonder if Tina maybe wants to say something as well about being not in the NHS, but in the care and health sector, because there's some tension sometimes there, isn't there, Tina, with people forgetting that hospices are largely charitable.
Yes, I think I can't add anything better to what you said, Jed, because a lot of my staff will be saying, look, they don't like to be seen as heroes. They're being paid to do their job. And they're saying, there's volunteers alongside us that aren't, giving off their time. Having said that, when I see how hard they're working, and, my concern is that they could be on burnout because they are absolutely working unrelentlessly for the benefit of others and overcoming, their fears in order to put the people that they are serving first. I think it's absolutely wonderful, because I think before this there was, you know, you did pick up some cynicism, some complaints about the NHS. You know, I talked about government bashing. There was definitely NHS bashing. And I'm so pleased that there is a valuing of the care services, whether that's nursing, medics, right throughout. And I'd say, you know, long may that valuing last, because it's really valuing people doing their jobs. And I think, well, tonight what I'll be doing is setting up my speaker, and we'll be playing Captain Tom's song because it's his 100th birthday. So I think as well, it's just reflecting the honour of the veterans who have kept us here today, and that link between I don't always believe in fighting talk or calling COVID a war, but it's an invisible war that is being fought, and the link between, you know, the heroes of Captain Tom's generation and those that are putting others before themselves on the front line of care. I just feel that it's an opportunity for me. It's a selfish opportunity to be able to honour them. So I love giving the clap, because it is an honour. And I said to my staff, well, you might not want to be a hero, but in my eyes you are. And you know, I want to do the gesture for you, so I will say my clap was tonight for Birmingham St Mary's Hospice, because I know how hard they're all working. So I think it is an opportunity for those of us, because as a chief exec, I've had those times where I've had no time in the day. I've overstretched myself to a ridiculous point on non-executive roles, on executive roles, on chairing the STP, on bringing people together. But now I've sat back and I thought, I'm not working like that at the moment, but my team certainly are. And so, you know, it's a great honour to be able to applaud them in that way.
Deirdre, if we have time, I have a question.
Yes, indeed. So I saw Peter Mayer's hand go up. You would like to ask a question, Clive?
So I'm the Governor of the Community Healthcare Trust, clinician and former chair.
I'll be with you in a minute.
The clapping has been very important for the Community Trust, such that my Council of Governors have been videoed doing the clapping for going out to all staff. The big issue for us at the moment is how we're going to support people who've recovered, especially if the Nightingale unit is used for rehabilitation, as is suggested. And clearly we're working jointly with the Mental Health Trust on that. But clapping, saying thanks in the public services is vital, and we're not very good at that normally anyway.
Was that an observation, Peter, or was that a question to one of the...
I'd got questions, but I thought with the time going, I'd just make the observation that, yes, saying thank you, in whatever way we do it, is vital.
Absolutely, 100%. I think we can all agree with that one, and we'll certainly be doing our own vote of thanks at the end. Clive, you had a question?
Yes. Don't think it's me.
Thank you, Jack.
Right. The expression psychological first aid really rang a bell with me, because we're fairly level-headed individuals within the Lunar Society, certainly within this group. We make an assumption often that the people that we interact with are similar. But I was wondering on two levels. First of all, we have a newsletter that goes out now every month to our members. And I'm wondering whether, using that wonderful 3 words, psychological first aid, there are any pointers that we should give to our members who all too often will not admit just the pressure that they are going through. So that's point one. Point two is, like many of you, my daughter is frontline as an anaesthetist in Manchester. My daughter-in-law is a frontline GP. And one of the things they don't do is talk to their parents and grandparents or their parents, because they don't want to worry us about the activities they're going through. And as part of the pointers, I would love to try to understand either now or within the thought process a bit later within the advice you give is, how do we deal with people who don't really want to talk, who find it uncomfortable to talk about what they're going through at this moment in time? I suppose that's first to Jed and then to Tina.
Okay. I mean, I think at the first point, on a really practical level, I'm very happy to send you some of the sort of forms of words and a little bit of short blurb, if that would be helpful. And I have some colleagues in the trust that are much more experienced than I am about psychological first aid, who are kind of leading on that training. And certainly, I think it's helpful. It's just helpful to name it. And I think putting it in your newsletter, it kind of gives people permission to maybe not be okay sometimes. So I'm very happy to send some stuff through either to Deirdre or whoever would be appropriate in the group. And then with how to support family members, I think there is something, and this is where there are some similarities with people who've been in combat situations. So often what they talk about is just not even really knowing how to explain the scenario and the environment, never mind what's happened and what they've been through. And a lot of frontline healthcare staff have had to do a lot of reassuring to their families and to their friends that they're okay. I can speak for myself. And my friends, there's a sense of wanting to reassure people that it's fine, it's all right, and we're it's not like it is on the news, or maybe it is like it is on the news. It depends. For some people, it isn't. And it's, I'm not on a hot ward or in a red ward. I'm not having to don the full PPE, but people's imagination is that everybody in the NHS is doing that very specific role. On the other side, perhaps what people don't see is what it might be like to listen to 300 or 400 people's experiences and stories over the past few weeks in drop-ins. So there's a sense of just respecting it, really, that sometimes people don't want to talk because they're too tired. It's the last thing they want to talk about when they come home is what they've been doing in the day, because they need to switch off and decompress. I think sometimes really practical things are really helpful. So my mum sent me something in the post off Amazon as a kind of, I don't know, I think she was just wanting to kind of know, for me to know that she was thinking about me, and so she sent something through in the post, and I received it, and we didn't even really get a chance to speak about it that day, but it was a really nice thing just to know that she was thinking about me, and that we didn't spend an hour and a half with me reassuring her that it had been okay in my day. So I think there's ways of showing family members that you're holding them in mind, but if possible, sometimes when we're trying to sort of talk to people, we're kind of almost reassuring ourselves, and I find myself doing it in staff support sessions, just being alongside people and letting them tell me what they want to tell me, or not tell me what they don't want to tell me, and that's okay. One of the most poignant things that a service user told me actually was that what they wanted from the people that were looking after them was kind eyes. And we're often really frightened to ask people what they want and need, because we feel that they might ask for something big or unreasonable or expensive. And actually, when you do ask people, they often ask for the tiniest things. And so kind eyes, or in this current climate, it might be kind ears, because you might be only on the phone with somebody. I think I've really held it, and I've passed it on a lot, because I think it really applies in this situation. And people just having the permission to not talk is okay.
Thank you.
Thank you very much, Jed. And yes, we would welcome the pointers. If you could send them through to David or myself, that'd be wonderful. I believe that Elizabeth Hensel wishes to make a point. Elizabeth? You have to unmute yourself.
How's that?
Oh, wonderful. We can hear you.
All right. I wanted to go back to something that Jed said. Well, I introduce myself, for those who don't know me. I am a retired clinical psychologist, though I'm retired from clinical work, but I'm doing lots of other things, including I'm a governor at the QA hospital, and I'm a member of the End of Life group. What I was interested in was Jed's point that when this is all over, pray God, cross fingers, that in fact mental health will be a lot higher on people's agenda and the status of it to be improved. But I'd actually like to expand that a bit to say, and I know Peter Mayer will know that this is one of my drums I've been beating for years, is that it's psychology as well, the study of why people do what they do and why they feel as they do, that needs much higher status in the way we set our strategies and we work our strategic plans. And I know that David Cameron introduced a nudge unit into government, which is actually using behavioural science for sorting out various ways to get people to change their behaviour. I think we ought to go much further than that and actually use our knowledge and our research abilities in how people do what they do and how they feel what they feel in terms of how we plan our future strategies and structures. That's all I wanted to say, really. It's not a question, it's a sort of point of view.
Thank you.
I just want to do triple thumbs up. I've only got 2 thumbs though.
Oh, thank you.
Thank you, Elizabeth. That was a wonderfully succinct way to bring us to the conclusion of this evening. So we're just going to hear from each of the panelists now with just their closing thoughts in terms of lessons learned and future actions that they can see moving forward. Just very, very quickly, 1 minute each. Tina, would you like to go first?
Yeah, and it partly answers, Clive also wanted me to answer that question, so it partly answers it. And it's very much how a crisis creates a big human force of energy. That means you can get things moving and it overcomes all obstacles. I think with clinicians, what we have to watch, and we had the conversation about this morning, is that often these are people that don't want to admit there's a problem themselves because they're so busy caring for others, which is, I think, Clive's point. And so what we haven't got answers for that in this crisis, but what we are setting up is time so that there's peer support when it's needed in the moment. And we recognise how important it is to have that support for people right in the moment in a crisis when things are happening. And what we're looking at constructing is a way of being able to support people with the fallout of that energy, that burst of energy. When that energy goes, how we can support people when they come through that and when the crisis starts to drop.
Wonderful. And Jed?
I was just trying to find a quote that the chief psychologist in our trust used in a presentation the other day, and it's by Maya Angelou, and I'm going to misquote her, but it was about there's no greater burden than an untold story. And I think what we must do going forward is to maintain space and create space for people to tell us their stories about this and about their work and what's happened to them, and for our patients as well. You know, people are going to respond to this in such a wide variety of ways, and although it's got this universal effect, the impact is really different on different people, and that I hope we can be kind and compassionate and allow for difference in people's reactions and responses, and sort of hold space for that going forward. And like Tina said, this mass mobilisation, I'm just amazed at what we can do when we're allowed. You know, we've put down some regulation and some governance and some procedure to great effect. And I really hope we hold on to some of that going forward, because it's been quite awe-inspiring.
It certainly has been awe-inspiring, and actually that just resonates with just one last point, because I want to make sure that everybody who asks questions or makes a point gets heard. Esther Boyd has asked if anyone shares her cynicism about the politicians who severely cut fund into the NHS and then ask us to clap the overstretched staff. So I think that type of thought process actually resonates with what you were just saying, Jed. I mean, what's this has shown me tonight is that we have to be eternally optimistic, as Jed is. And it's that optimism that actually drove people like Tina and her staff to ensure that they were able to have agile responses to this pandemic. And then for us to be able to create that space and maintain that space, to be able to tell that story. And I love the idea of the kindness. And it's not a word that we've heard previously in any strategic forum in the way that we speak, but it's wonderful that it's actually a word that's been part of our dialogue and narrative now. So as we get ready to clap for our NHS, for our carers, for our frontline staff, for those behind the frontline staff, and having gained that greater understanding about the impact of austerity on the NHS and the social care workforce, I want to just say, thank you to all of you for being on the call this evening. It's been my personal honor and pleasure to share this space with you. I would like to firstly thank our panelists, Tina and Jed, and thank them in the usual way.
I'll clap you.
And I'd like to virtually also thank Sharon. I'm certain that she would be here if she could have. I expect that technology got the better of her, as I know it definitely does me. My 18-year-old despairs of me with the way that I deal with technology. So
well done for being Sharon to you, Deirdre, as well.
Yes, absolutely. Oh, so claps for Sharon as well. So we have recorded this event. I have to admit that I've taken a photo of us. If you wish not to be in the photo, because we are going to promote this on social media, please do let us know. And if anyone who is not a member of the Lunar Society would like to join us and be part of these incredible discussions that we do have, and genuinely, in terms of catalyzing action, we've spoken about government needing to know and understand that mental health and psychology are not to be marginalized. And certainly through our membership and through the power of the influence of the Lunar Society, we would do our utmost best to support that moving forward. So we are about the stimulating the ideas, the broadening debate, and I hope you'll find that we have had a really good discussion and catalyzing our action. So it just leaves me now to ask us to just do a clap for our NHS, our carers and our frontline staff and all those behind them before we go off to clap ourselves at 8 o'clock.
We unmute.